Hello everyone. We are here for the next lecture now, and for this we have a wonderful personality, a lovely orator, and one of the stars in diabetology in the world. So I am going to introduce Dr. Samuel Dagogo Jack, who is here with us today for an important topic. He has the A.C. Mullins Endowed Chair in Translational Research, Professor of Medicine and Director, Division of Endocrinology, Diabetes and Metabolism, Director, Clinical Research Center, the University of Tennessee Health Science Center at Memphis. And now, Shilpa Joshi, my co-moderator, is going to tell you the topic that Dr. Sam is going to speak on.
Hello, everybody. It's my pleasure to welcome Dr. Sam. He's going to speak on non-pharmacological reversal of prediabetes and restoration of normal glucose tolerance. Dr. Sam, can I request you to share slides, please?
Thank you. Can you all see my slides?
Yes.
Yes.
Okay. Thank you, Doctors Nita and Shilpa. And welcome, everybody. I think it's good evening over in India, good morning or good afternoon somewhere else. It's my pleasure to join the fourth IDEC conference. Here are my disclosures. There is no pertinent conflict regarding the subject of prediabetes because no drug is yet approved for it. However, toward the end of my talk, I'll mention some drug classes for my upcoming project. So for that reason, here are my disclosures, including clinical trials, contracts, NIH funding, and paid consultant positions with various industry members. So my objective today is to impress upon the audience the importance and rationale for aiming for reversal of prediabetes versus merely preventing type 2 diabetes. In the course of my presentation, I will discuss the complications associated with prediabetes and the effects that one can expect when prediabetes is reversed to normal glucose tolerance. I will share data from our long-running POP-ABC study and then more recent data regarding reversibility of the prediabetic state and future directions. So individuals born with normal glucose tolerance develop type 2 diabetes by first passing through an intermediate stage that we now recognize as prediabetes. The rate of initial transition from normal glucose tolerance to prediabetes is not widely known because few studies have explored that proximal stage of glucose dysregulation. However, the literature has information from the Baltimore longitudinal study on aging, where persons with normal glucose tolerance developed impaired glucose tolerance or impaired fasting glucose at a rate of 6.2% per year. The Baltimore cohort is 94% Caucasian, so the numbers may not be generalizable. The second study in the literature is that conducted among the Pima Indians of Arizona. And there, Drs. Nola and colleagues reported a transition rate from normal glucose tolerance to prediabetes of nearly 8% per year. But that again is a specific tribal group of Pima Indians. In our own study that enrolled offspring of African Americans and Caucasian parents with type 2 diabetes who were studied from the state of normal glycemia until prediabetes, we reported an incident rate of prediabetes of 11%. Once people have developed prediabetes, the rate of decline into full-blown diabetes varies by population studied, but generally ranges from about 10% in the US to as high as 18% in the Indian study. That is the Asian Indian study, IDPP1. We now know that intervening in people with prediabetes is very rewarding because one can slow the progression to type 2 diabetes, but not only that, one can also deliver important benefits. Those benefits were best illustrated in the longest diabetes prevention trial ever conducted, the so-called Dacheng Diabetes Prevention Outcome Study. After 30 years of follow-up, the group has now been able to document significant reductions in the risk of cardiovascular events and death in people who pursued a lifestyle intervention that prevented type 2 diabetes. And all of the participants had prediabetes at baseline. The Dacheng investigators calculated the numbers needed to treat and obtained a very impressive 10% number as people who needed to be treated for prediabetes in order to prevent one death. So the NNT of 10 is highly impressive and lower than what has been reported for other intervention studies that use death or CVD outcomes, such as the statin studies. In addition to the Dacheng study, numerous other randomized controlled trials have reported efficiency in preventing type 2 diabetes among people with prediabetes. But notice that the reported range of benefits is far from 100%. In the DPP, in our own study, as in the Finnish study, the risk reduction relative to placebo was 58%. The highlighted studies in blue font are those that employed lifestyle intervention, and you can see that the range is modest from about 26% to as high as 58%. So a substantial number of pre-diabetic individuals, even after being enrolled in a carefully and rigorously conducted diabetes prevention intervention, remain pre-diabetic, even though diabetes has been prevented. Why is that important? In my opinion, that is important because pre-diabetes is a toxic environment for the initiation and propagation of multiple vascular complications. Diabetic retinopathy has been documented in nearly 9% of people with prediabetes, and 14.7% of people with prediabetes have chronic kidney disease up to stage 3, can be documented even before diabetes occurs. Peripheral neuropathy, that is symptomatic, has been documented in the pre-diabetic population, and in some studies, such as the one from Michigan, nearly 40% of pre-diabetics may have symptoms of neuropathy. And of course, we all know that pre-diabetes doubles the cardiovascular mortality based on the Paris prospective data. So pre-diabetes is not a benign condition. And if an individual with pre-diabetes is enrolled in an intervention program that prevents type 2 diabetes, we want to make sure whether it has also erased pre-diabetes and reset the metabolic clock back to normal. That is the essence of my presentation today. The RCTs have shown that type 2 diabetes can be prevented using a number of approaches, lifestyle or certain medications. However, persistent prediabetes is the result of many of these interventions, even though they declare victory that they have prevented diabetes. But the patients, a substantial proportion of the patients remain pre-diabetic and therefore at increased risk for complications. Now, very few studies have pre-specified reversal of the pre-diabetic state as primary outcome. So what I've done is to milk out from the data published that the studies that made mention of numbers that reverse back to normal glucose tolerance, and pool those studies to share with you today. In the Malmo study, which was basically a feasibility trial, they reported a 52% rate of reversal from prediabetes to normal glucose tolerance following lifestyle intervention. In our DPP study, the intensive lifestyle group experienced 40% reversal, 40% of them experienced reversal as compared with 20% for metformin and 20% for placebo. So metformin was no different from placebo, and individuals on placebo who spontaneously reverted from prediabetes to normal glucose tolerance may be expressing the so-called Hawthorne phenomenon because they were enrolled in a study that was serially measuring them on repeated visits and weighing them, so they may have altered their behavior. The Indian Diabetes Prevention Program, performed out of Chennai, Dr. Machandra and his colleagues, in the second iteration, IDPP2, have data to support 32% efficacy of lifestyle at restoring normal glucose tolerance in previously pre-diabetic individuals. And one study, which was not a diabetes prevention program, but which I've included here, is the liraglutide 3 milligram study. It's an obesity study. However, they had a placebo group where placebo and lifestyle achieved 36% reversion from the pre-diabetic state in the subgroup of participants in the SCALE trial who had pre-diabetes. So if you look at the numbers, they are either less than the numbers quoted for diabetes prevention or in the range of about 30 to 50% that can achieve reversal on lifestyle intervention. Medications can achieve more, but those medications need to be continued for the glycemic efficacy to persist. And within 3 months of stopping any of these drugs, rosiglitazone, pioglitazone, or metformin, glycemic rebound had been reported. So what can one expect when one reverses prediabetes back to normal glucose tolerance versus not doing so? We have very interesting data from the diabetes prevention program. Recall that that program did not pre-specify reversion to normal glucose tolerance as a primary endpoint. The primary endpoint was prevention of progression to type 2 diabetes. However, when Lee Perol and some of us looked at the overall data and identified among the 3,000 DPP participants those whose blood glucose ever reached normal glucose regulation, even once, ever reached during the course of the DPP, versus those who were, all of them are enrolled with prediabetes and they never hit the normal glucose range throughout the study, those two groups separated when we evaluated the future risk of diabetes during the extension study. So the DPP ended in 2002, and then we were funded for a follow-up study, the DPP Outcomes Study, DPP-OS. So during DPP-OS, if an individual's blood glucose during the previous 3 years of DPP ever reached normal, they had a 56% reduction in the risk of future diabetes. So we looked at those who were able to have their blood glucose hit normal range, and we found that the predictors were that they were assigned to lifestyle intervention, and they achieved weight loss goal of greater than 5% from baseline by the 6th month of intervention. Individuals who reverted to normal glucose tolerance were more likely to do so if their baseline fasting glucose and 2-hour plasma glucose were in the lower range of the group cohort spread, if they were younger, and if they had evidence of robust insulin secretion. We then asked the question, since this was a dichotomous evaluation, ever reaching normal versus never reaching normal, and in the course of 3 years of follow-up, we were assessing them annually with OGTTs, what if somebody reached only once, and then the next assessment, the glucose has jumped back to pre-diabetes, and another person normalized only on 2 occasions or 3 occasions? Was there a relationship between how many times a pre-diabetic patient's blood glucose dipped down into the normal range. And surprisingly, there was a relationship. So you can see here that if an individual reached normal glucose regulation just once, their future risk of diabetes was decreased 47%. 2 episodes of normalization associated with 61% risk reduction, and 3 episodes, nearly 70% risk reduction. So even though these were transient dips into the normal range, they were registering metabolically. There was some metabolic memory of that transient normalization that predicted decreased risk of future diabetes. Now, how solid is this decreased risk? And can we determine accompanying benefits? Yes, we can. In a recent paper we published from the DPP cohort last year in Diabetes Care, we asked the question, does regression to normal glucose tolerance, even if transiently so, reduce the risk of microvascular complications? And we used generalized estimating equations to compare the prevalence of aggregate microvascular complications, including retinopathy, nephropathy, and neuropathy, among those DPP participants who reached normal glucose tolerance at least once versus those who never reached normal glucose tolerance. And impressively, there was a 22% reduction in the risk of aggregate macrovascular complications in those who reached normal glucose tolerance versus those who never did. And similar results were observed for nephropathy and retinopathy. So we concluded in that paper that regression to normal glucose regulation is associated with a lower prevalence of microvascular disease, primarily due to lower glycemic burden over time. We've also reported that risk factors for cardiovascular disease benefit from transient restoration of normal glucose tolerance from the same cohort. But those are risk factors, not events. As you know, the DPP outcome study is still continuing, and we're capturing actual cardiovascular events, mortality events, etc. So we don't have event rate analysis for transient normalization. However, there are data from other studies I will show you. One small study from Michigan followed 32 subjects with prediabetes, enrolled them in an aggressive lifestyle intervention that normalized their glycemia into the normal glucose tolerant status. They were then assessed initially at baseline and after 1 year of glycemic normalization, and the assessments were extensive, including 3 millimeter skin biopsies with microscopic measurement of intraepidermal nerve fiber density, which is an objective measure of peripheral neuropathy. Now, all of the 32 subjects had symptomatic classical diabetic peripheral polyneuropathy, even though none of them had diabetes. As I mentioned earlier, pre-diabetic complications are seen frequently. So after 1 year of normalization, the biopsies were repeated, and what you see is that at baseline, the intraepidermal nerve fiber density in the pre-diabetics was low, 8.2 fibers per millimeter, showing nerve fiber loss or neuropathy. And 1 year after glycemic normalization, the numbers increased to 15.1, and there was microscopic evidence of re-innervation. So this is a pretty powerful data, albeit from a single center and few. More recently, last year, data emerged from the White Hall 2 observational cohort, in which 5,193 subjects with prediabetes were stratified by their pre-diabetic status into IFG, impaired fasting glucose, IGT, the 2-hour OGTT value being above 140, or A1C. So 3 criteria for pre-diabetes were registered at baseline. Then they were assessed between 2002, 2004, and again 2007, 2009, a 5-year interval. During that period, those whose blood glucose normalized were assessed for the outcome of cardiovascular disease events or death. And what was reported was that normalization of the 2-hour plasma glucose was associated with significant, nearly 50% decrease in the risk of death or cardiovascular events, even after adjusting for age, gender, and prior history of cardiovascular disease. So I have shared with you the rationale for aiming for reversal, and the rationale is underscored by our ability to impact the pre-diabetic complications, both in the microvasculature and in the macrovasculature. So in addition to preventing future diabetes, we are able to impact significant reduction in the risks of microvascular disease, cardiovascular disease, and death if a pre-diabetic individual is no longer pre-diabetic. So I put it to you that our goal should be more ambitious in people with pre-diabetes beyond preventing future diabetes. We should actually aim to normalize. So now, next phase of my presentation addresses our study, the POP-ABC study, and its follow-up study, the PROP-ABC study. Many in the audience may have heard presentations about my study, the POP-ABC study in Memphis that has been running since 2006. In that year, we enrolled nearly 400 African Americans and Caucasians, all of whom had biological parents with type 2 diabetes. The individuals were aged 18 to 65 years, and they must pass a screening OGTT by showing normal fasting glucose NFG and normal glucose tolerance. If they did that, they were enrolled into quarterly follow-up for 5 years, during which they were extensively evaluated. At the end of 5 years, we assessed outcomes. Those who remained normoglycemic were called non-progressors, and those whose glucose had drifted from the normoglycemic status to IFG, IGT, or combined IFG, IGT, or even type 2 diabetes were all collectively referred to as progressors. 11 people developed diabetes. The majority went through pre-diabetes, so we limited our analysis to the pre-diabetic progressors. And what we did was, during the serial visits, 3 monthly visits, we measured a bunch of stuff. Almost all of the known metabolic assessments were accomplished in them. We even did proteomic and metabolomic analysis. And the primary results showed that about 30% of the cohort developed pre-diabetes from their initial enrollment normoglycemic status, and the average annual incidence rate of pre-diabetes was 11.2%. Surprisingly, the black and white subjects had exactly the same rate of incident pre-diabetes, leading to the conclusion that having parents with type 2 diabetes abrogated any ethnic disparities in dysglycemia, and that parental history was such a powerful risk confirmant that race ethnicity no longer mattered. So we've published that. Because we are extensively assessed our cohort, we were able to contribute to the literature regarding the triggers for departure from normoglycemia toward prediabetes. And those publications are in the public domain, and I won't have time to go through them, but we've contributed a lot in that area. But in a nutshell, what we've shown is that the usual suspects that lead to type 2 diabetes are fully in operation in the earliest stages of escaping from normal glucose toward prediabetes, including insulin resistance, beta cell dysfunction, increasing weight and body fat, adipocytokines, dyslipidemia, certain amino acids in our metabolomic assessments, specifically histidine and asparagine, were upregulated in progressors. Octanyl carnitine, acyl carnitine, and tetranyl carnitine, these are short-chain acyl carnitines, which were elevated in progressors. We recently had data for microRNA that were presented at the ADA meetings, and we're exploring other predictors. So prediabetes is predictable among people that are studied from the state of normoglycemia, and some of the prediction models are quite robust. So in 2012, after completing the 5-year follow-up, we approached the NIH for funding for a follow-up study of the original cohort, which we now called the new study PROP ABC instead of POP ABC, the R representing reversibility. We reasoned with the NIH grant reviewers that because we have a unique cohort of high-risk subjects with parental type 2 diabetes, whom we enrolled with normal glycemia and followed up in real time and watched them develop prediabetes in real time, we might be able to intervene promptly to try to prevent type 2 diabetes and better still, to reverse the prediabetes, because these are incident cases of prediabetes prospectively identified, and therefore we knew when they had the prediabetes. And we would enroll them into intensive lifestyle intervention. Fortunately, the grant reviewers agreed with us and funded us with more than $3 million to follow the cohort for another 5 years. And those who already had prediabetes were immediately enrolled in lifestyle intervention, and the individuals remaining normal were studied quarterly, and any new cases of progression to prediabetes was immediately funneled into lifestyle. And people remaining non-progressors were just observed over time. So the PROP ABC is a follow-up of the POP ABC, the difference being that now we're not just watching people develop prediabetes, but we're intervening to do something about it. The intervention we used was non-pharmacological. We focused on lifestyle intervention. And our protocol was more intensive than the DPP or look ahead in terms of physical activity goal. The weight loss goal was 10%, which was same as look ahead, but higher than DPP. Our monthly face-to-face meeting schedule frequency was intermediate between DPP and look ahead. We used targeted meal replacements in addition to several other behavioral interventions and special campaigns. It was a very extensive and laborious intervention. The protocol for the lifestyle is under review at a major journal for publication. And what we found was that 210 individuals from the original POP ABC agreed to re-enroll for the PROP ABC. The gender ratio, mostly predominantly female. There's an obese cohort, BMI is nearly 31. And among those at the end of the 5-year follow-up period who developed prediabetes, we stratified them to those whose prediabetes was less than 3 years from our reckoning before they started the lifestyle intervention, and those who had the longest latency of prediabetes before lifestyle intervention started. The overall range of prediabetes diagnosis before initiation of lifestyle was 3 months to 8 years. One of the sub-hypotheses we were testing was that there may be a time dependency to the ability of interventions to reverse prediabetes, and the latency may be dependent on how long an individual had been prediabetic. In other words, if your prediabetes was detected today or yesterday, we hypothesize that it may be in a more nimble state, and interventions might be more successful. Whereas if you've had prediabetes for many years, it may be more difficult to prevent diabetes or reverse it. So in all, we had 138 progressors to prediabetes, and the 72 non-progressors did not receive lifestyle. They didn't need it. Their glucose levels were perfect. And in the course of 5 years of lifestyle intervention, when we compared the two groups, those receiving intensive lifestyle and those not receiving any, there was significant decrease in fasting glucose, significant decrease in weight, and a trend towards significance in the decrease in 2-hour OGTT value in plasma glucose. Here is the serial measurements in weight. The red bars indicate those receiving intensive lifestyle intervention. The blue bars, the control group. As you can see, the natural tendency for people who are not following any lifestyle and who are middle-aged and pre-diabetic or healthy, the national tendency is to pick up a few pounds over the years, and we saw that. But because of the efficacy of the lifestyle intervention, there was a progressive decrease in weight. We also found a decrease in fasting glucose that was sustained over time. And when we assessed the glycemic outcomes after 5 years of intervention, we found that incident type 2 diabetes was extremely low, occurred low, only in 6.5% of our cohort. Remember, this is a high-risk cohort of biological parents with type 2 diabetes who were enrolled, and we watched them develop pre-diabetes and intervened. And in that cohort, we were able to prevent diabetes in the vast majority. However, we found that only 43.5% were able to achieve normal glucose tolerance. And 50%, although they did not develop type 2 diabetes, were chronically pre-diabetic. They remained stubbornly pre-diabetic. When we now tested the embedded hypothesis as to whether the ability to reverse the pre-diabetes would be somehow related to how long an individual had been pre-diabetic, we were quite surprised to find the following. Those who had the short duration pre-diabetes before initiation of lifestyle intervention, reversion to normal glucose regulation occurred in 44%, and the equivalent number was 42% in those who had had longer duration, and even the longest duration pre-diabetic individuals before initiation of lifestyle achieved 45% reversal. And the chi-square test showed no significant difference in the reversibility of pre-diabetes as a function of duration of residence in the pre-diabetic state. The other outcomes, development of type 2 diabetes or persistence of pre-diabetes, were also not dependent on the duration, at least in our cohort whose range of duration was 3 months to 8 years. So individuals who are prospectively determined to have developed pre-diabetes responded to lifestyle intervention, even though they had had the pre-diabetes for 3 months to 8 years. And the good news is that in this cohort, the overwhelming majority could be prevented from developing type 2 diabetes. This number is unprecedented. We're actually scared to talk about it because it's so high. It's higher than what has been found in the DPP or any other diabetic prevention program. And we argue that that might be because in DPP and other studies, individuals did not know how long people had had pre-diabetes, and some may have had it so long that their beta cell function had declined. And in our own cohort, we knew when they had the pre-diabetes and intervened promptly. So that's the good news. The bad news is that despite the intrusive, laborious efforts we brought to bear in these prospectively diagnosed cases of pre-diabetes, 50% stubbornly remained pre-diabetic. We could not reverse them. We could reverse only about 44% back to normal glucose tolerance. So with that backdrop, I have decided that we may need more than lifestyle to reverse pre-diabetes. So I want to introduce you to a study we're launching called the Crucial Study, which is complete remission using cyclical incretin and lifestyle intervention. We are enrolling adults aged 18 to 65 regardless of family history of diabetes. We use OGTT at baseline to screen them to make sure they have pre-diabetes, and we will include people with recent onset type 2 diabetes of less than 2 years duration. After screening and eligibility criteria, we'll enroll them into intensive lifestyle intervention for 6 months, and we'll perform baseline assessments. After 6 months, if they've reversed to normal fasting glucose and normal glucose tolerance, and A1C is less than 5.7%, we'll declare them as winners. We'll call them intensive lifestyle intervention remitters, and we'll continue the ILI. Those who persist in their pre-diabetic state or their early type 2 diabetic state will be called ILI resistant, lifestyle resistant. And we plan to randomize that group to metformin plus lifestyle or GLP-1 RA plus lifestyle. We'll discontinue the medications after 6 months of intervention, perform oral glucose tolerance serially, test serially, and if those people who respond by remission to fully normal glucose occur, they will be continued in the observation phase without drugs to see how long the remission will last. And as we predict, some will not remit, and they will have a second cycle. After the 6-month break, a second cycle of drug intervention, and this will be iterative. And those on follow-up previous remitters who relapse, as may occur theoretically, they'll be funneled into another cycle. And we'll do this for 3 cycles before determining how many people failing initial lifestyle could be redeemed with medication intervention. And we hypothesize that a finite number will do so. The primary outcome will be complete remission as indicated by normal glycemia off of medications for at least 12 months. Secondary outcomes include reversing type 2 diabetes to prediabetes and a number of biomarkers. So to summarize, I've told you that lifestyle and drugs can prevent type 2 diabetes, that the pre-diabetic state persists in nearly half of at-risk people, and that prediabetes is associated with toxic manifestations in the vasculature, and therefore we should aim to reverse it. However, the lifestyle interventions that prevent type 2 diabetes do not reverse prediabetes in most people. And given the compelling benefits of restoring normal glucose regulation, reversal of prediabetes ought to be the standard of care. In order to accomplish that, we will need novel interventions besides lifestyle modification. So at this point, I'd like to thank the sponsors of my research, the NIH, ADA, and the state of Tennessee. Most importantly, the selfless participants who joined our studies and have come year after year, and of course, my able team that have enabled execution of these studies. At this point, I thank you very much for your kind attention.
Thank you, Dr. Sam. We will just have one single question because we're really short of time. If you could just stop sharing the screen. Yeah. The question that I want to ask was that you showed us data about cardiovascular disease outcomes, CVD risk markers, and microvascular disease. Do you have such similar data for these reversal patients on NAFLD or NASH?
We do not, but we have biomarkers, mostly enzymes, transaminases. We've not analyzed them, but it is on our to-do list.
Okay.
Good question.
All right. Thank you very much, Dr. Sam. That was a very illuminating talk, and we shall end this session right here.
Thank you.
Thank you very much. Thank you.